very good morning to all, and thanks for braving the traffic to be here this morning. My name is Phyllis Kim. I'm a medically trained professional, and I specialize in public health. And I've been head of the Evidence to Practice Office for the past 2 years. Our team of over 20 guideline developers are here today to help you go through the evidence to recommendation framework. Essentially, our team deals with formative research, which deals also with topic prioritization for the guidelines, and we've just opened up our guideline topic prioritization. I hope that we see lots of submissions this year. We also have a team that oversees the guideline development proper, as well as evidence implementation, which is often neglected, but we hope to elevate that practice. Today, I would like to present to you our overall objective. As some of you may be aware, earlier this year, we sent out a survey to many of you to check what are your needs in terms of evidence-based practices. And in response to that, today we want to focus on the evidence to recommendation framework, just a snippet of how the team develops the guidelines. You also have an amazing opportunity to have a hands-on stab at translating the evidence to recommendation. What was really fun was last week, my team and I, we went through a dry run of today's framework. And it was very interesting. We had all the evidence submitted to us, and in little groups, we tried to come up with based on the certainty of evidence, values and preferences, resource implications, and cost-effectiveness considerations. When it was so plainly laid out to us, we still came up with very different views on how the recommendation should look like in the end. So it is quite a complicated process as we try to second-guess what the clinician's needs are, what the patient's needs are. So I hope that you will also find this very insightful, very interesting, and fun as well. I just wanted to state our long-term vision. We want to support evidence-based medicine as the foundation for delivering appropriate care. As most of you here are healthcare professionals, we really would like to partner with you to this end. So today, later on, we are soft launching the ACE repository for clinical guidelines. It is going to be the single platform to house all the guidelines that are developed locally by yourselves as well as by us, or those that in collaboration with each other, those that meet the guidelines for guidelines minimum standards will be placed in this repository if you sign up for it. And we're very happy to partner with you to see that end. So for now, we have a very, very packed morning. So without any further words, I will commend you to the team to crack on with it. Thank you very much.
Good morning, everyone. Okay, thanks so much, Phyllis. Good morning, my name is Valentina. I'm a guideline developer at ACE, and I lead the team that looks after the ACE clinical guidelines, or ACGs. It is my pleasure to welcome you all today to this workshop, and really our pleasure to share our experience in developing the evidence to recommendation frameworks. So this is what we're going to cover today. Between now and 10, we'll go through the basics of ETRs, or evidence to recommendations, before we dive into an exciting hands-on exercise that will give you the opportunity to try the ETR yourself. For this first part, I will focus on what ETRs are and why they're so important in guidelines. Now, before we begin, can I please get you to scan this QR code? It is a Slido QR code. You will find 2 sections on your phone. One is called Q&A. You can send us questions at any point during the session today. And another one is called polls. So we'll use this one to get warmed up in a minute. Now for questions, it's a very large crowd today, so we seek your understanding that we'll try and get to as many questions as we can. But if we don't get to your question, please come and find us during the breaks or after the workshop. Okay, so hopefully everyone has scanned, so we can get started. I have one more question for you, and perhaps this is the million-dollar question, all right? What factors would you consider if you were appointed to a panel that is trying to make a recommendation for a medication in a national clinical guideline? What would be the things that you would want to know, that you would want to consider to reach a recommendation for the guideline? Safety, efficacy, evidence in general, yeah. Efficacy versus side effects, cost, acceptance, NNTs, number needed to treat, many different factors, some really converging, yeah, towards evidence, efficacy, cost, safety versus effectiveness, and current practice, all very valued. Patient outcomes as well, yeah. So once again, lots of different considerations and all very relevant. Great, if I can just get back to the slides, thank you so much. All right, thank you so much for your submissions. I think this quick exercise was just there to show us that whenever we're making a decision, whichever this decision is, it can be multifaceted. And if we put this in the context of healthcare, then it's even more so. That's why we have structures and tools that can help us have clarity through this process and ensure that all the relevant considerations, all the relevant factors are taken into account when reaching a decision. So first things first, what is an ETR exactly? Well, ETRs are just simply a tool that can help you moving from your clinical studies or any other type of evidence to a guideline recommendation. Often this is a challenging step, and having an ETR allows you to follow a structure and be systematic in considering the important factors that you want to consider when crafting a recommendation. Perhaps you've heard of them before, called also evidence to decision frameworks or ETDs. These two names are interchangeable, so if you look up the evidence and you find ETDs, they are the same thing as ETRs. Now, which factors do ETRs consider? Well, there are several, and different ETRs may have slightly different set of factors. To identify the most suitable set of ETR factors, we first need to determine which perspective our guideline is taking. There are two common perspectives. The most used are a population perspective, also referred to as a health system perspective, or an individual patient perspective. Now, depending on the perspective that you choose, your ETR may be different, or perhaps the type of information that you consider for your factors will be different. Here we have an example about judging resources and feasibility for psychotherapy as an intervention. If you take an individual patient perspective in your guideline, the orange side of the slide, you would probably consider or ask yourselves questions like, is the patient able to engage in the psychotherapy? Is it receptive to receiving such service? Now, if you're looking instead at a population perspective, you may still ask these questions, but you should probably also take into account the availability of psychotherapy providers nationally, what's the current waiting time, other feasibility barriers, or other resources constraints. At ACE, our guidelines take a population perspective. And for the purpose of this workshop and the exercise later on, today we'll mostly focus on a population perspective approach. So as I was saying, there are existing ETR frameworks available. We don't have to always come up with one from scratch. Here you see a non-exhaustive list. GRADE at the top is the gold standard, and many organizations have used it in their guideline work. ACE is among these, alongside the WHO, NICE in the UK. And this matrix really shows you which factors are taken into account by different ETR frameworks or different organizations. For example, NICE makes cost effectiveness one of their critical consideration under the resources domain in the ETR. In contrast, you see the United States Preventive Services Task Force, which intentionally leaves out cost effectiveness in their ETR and final decisions. This is mainly due to differences in the context and in the health system that they serve. The British NHS is a universal healthcare coverage system, the US is not, and it's more fragmented. So, let's elaborate now on why do we bother, why do we need to use ETRs? Now, to do that, allow me to step back for a minute and define what clinical guidelines are or should be. You see on the screen the definition from the WHO in the recent Handbook 2023. Trustworthy guidelines are the cornerstone of giving evidence-informed advice in response to clinical, public health, and health policy questions. They address those questions by using best available evidence and transparently integrating the judgments of experts and the input of the stakeholders in the process. And that's exactly where the ETR can help you. They provide structure for evidence use, and they give transparency to the judgments of your guideline panel. So if you intend to develop a trustworthy, high-quality guideline, ETRs are really a non-negotiable step. Now, I just want to make a note that ETRs are truly important, of course, but they're not the only good quality or standard for trustworthy guidelines, all right? There are other things that we need to put into place, like having a good COI management policy, having good representation in your panel, being systematic in your evidence. So there are other tools that can help you making sure that your guideline is of appropriate quality. But for the purpose of today, of course, we'll focus on the ETRs. Right, so back to it. How do ETRs provide structure? They essentially stipulate what considerations will weigh into each recommendation, and by doing so, they minimize the potential oversights in judgments. It is not surprising that if you look into the evidence, guidelines that use ETRs were found to have more comprehensive assessments during their judgments, lending to the guidelines' trustworthiness. My colleague Johanna later will present some examples of how stopping just at the evidence point will lead to quite different conclusions when you make recommendations compared to include more ETR factors in the panel's judgment. So here's the first takeaway point for today. Use an ETR when developing a guideline to avoid oversights in decision making and enhance your guideline's quality. Now, besides structure, ETRs are essential to make sure that the judgments are transparent and clear to your users. Users could be healthcare professionals, policymakers, other guideline developers that wish to adapt from the work that you've published, or even patients. And transparency is key as an enabler of adoption. Here we have an example of two guidelines on gout. They reached a largely similar recommendation on using allopurinol first line. Now, the key difference is that the first guideline used and published an ETR, the second did not. So users of the first guideline could see that the recommendation was based on high quality evidence, cost considerations, and concerns with the alternative drug. Now, we know that each patient is different, and transparency of this guideline allows clinicians to tailor the recommendation if needed. For example, there may be patients for whom cost is actually not an issue, and the alternative drug could be used first line, having considered the patient's risk profile. In addition, should there be new studies, new information emerging among for the evidence, the costs, or the harms, users can actually make a judgment about how this new information will tweak, or perhaps not, the ETR and therefore the corresponding recommendation. So you might be wondering, right, so does it mean that guidelines on the same topic using a largely similar ETR would all reach the same recommendations? Surprisingly, no, this is not the case, and here is a very clear example from British guidelines on asthma management. They specifically looked at adding on treatment after inhaled corticosteroids or ICS. Very interesting to see that they both used a population perspective, they both crafted guidelines for the same geographical context and healthcare system, yet they recommended two different treatments as add-ons to ICS. This is because the ETR does not replace the panel's judgment. It is simply a tool, and it's up to the panel, the guideline panel, to make a conclusion based on the mix of the factors in the ETR and the weight that they want to put on each and every factor. For example, NICE here clearly stated that economic considerations were prioritized over other factors, leading to the recommendation for leukotriene receptor antagonist of LTRA instead of long-acting beta agonist, LAVA. Once again, transparency is key so that the recommendation can be read alongside the judgments that led to them. Another case studies, 2 guidelines looking at systolic blood pressure targets. They both looked at the same trial, but their judgments on the balance of benefits and harms associated in this trial differed, which led to 2 different recommendations in the way that they positioned the blood pressure targets. So, allow me to highlight that if you're using our guidelines, or perhaps after today you will refer to our guidelines, you can find ETRs published alongside them. You can access them either on our website or through the QR code that's at the back page of the ACG itself. We have very large expert groups that help us throughout the guideline development. They help us develop these ETRs, they review them, and they approve them before publication. Now I have a last segment for my presentation, and I wanted to clarify a quite practical and crucial aspect. When do we do all this work? At what point of the guideline development do we bother with ETRs? There are 2 main actions for you to take note of. One is about planning an ETR, and the second one is actual drafting and completing the matrix. Now, planning should happen early. This is so that you can stipulate and agree among the panel the perspective of your guideline and the ETR factors that you will consider. This is so that you're not biased. You haven't seen the evidence yet, you haven't come together to discuss or deliberate. You a priori decide, right, these are the factors that we're going to take into account when coming up with strength of our recommendations. Now, drafting an ETR happens after, of course, you gather the evidence. I think that's quite self-explanatory. Here we have another way of seeing it. This is an overview of the process involved from the NHMRC in Australia, specifically looking at completing the ETR after you've gathered your evidence and you've synthesized it. Recommendations are crafted after you've completed the ETR. So you have your ETR, you've done your homework in terms of filling the various factors, and then that's the basis that you have to come up with the recommendation wording. Here again, another way of looking at it, this is a figure from core grade, and you can see very clearly that there is a stage for planning, then you move to your systematic review, and after that you will take into account what you found to populate the ETR. So, the important takeaways: determine the ETR type before evidence work and deliberations commence, and complete the ETR after you've done your evidence synthesis. Alright, we are at the end of this session, and we have just a slide to summarize the key conclusions. First of all, ETRs are tools. They don't replace the panel's judgment. They are important though, for structure and for transparency. And guideline teams or guideline panels should select ETRs at the beginning before the evidence work starts and deliberations commence. We're at the end of the first session. Before I pass it on to my colleague, you can send us your questions about what was just discussed. You can also just raise your hand. We want to keep it as interactive as possible. Someone will come to you with a mic, and I'd be happy to take any queries on what was just presented. I'll check on Slido to see if anyone sent through some queries already. Very important. Will we be receiving the slides? Yes. It's a fairly large file, but we'll find a feasible way to share them. Any other questions on what was presented? Not for now? Okay. You can always catch us during the breaks if you have more queries. All right, so then without further ado, I'll invite Johannan to come on stage. He'll take you through the how to complete an ETR. Thank you. Just a question, so I guess I'll take this now. Can you share how weightage is derived from the various domains? Very important. Johannan will go through this a little bit more in details. There is no right or wrong, okay? The guideline panel can make a call on what's more important, what factors should take precedence, so to speak, compared to others. Now, as a rule of thumb, it is advisable to start from the evidence, i.e. the benefits and risks that you have identified in the studies, and make a judgment about what's the balance, what's the ratio. Is this intervention that we're looking at highly effective, but also associated with high rate of adverse events? So that's a very good place where to start, alongside the certainty or the quality of that evidence. So I think if you're planning to do an evidence-based guideline, then that makes sense, right? When you're looking at ETR, that could be a very good starting point for you to put weight on that factor, and then layer the other considerations as required. There will be some examples later as well. Sorry, I saw more popping up, so let me just check. At what stage are clinical guidelines revised? Is it when new drugs are approved? Very good question as well. If you have a chance, please check on our website. We published a document called Guidelines for Guidelines, or in short, G4G. It's a simple set of 9 requirements or 9 standards that we hope all guideline developers can adopt during their work. And one of them is to make it explicit as to when you plan to review or revise your guideline. Again, no right or wrong in this case, as long as you're transparent. At ACE, we minimally look at our guidelines every 5 years. If we know that there is newer, very significant evidence earlier than the 5 years, we would do that prior to the 5-year mark. If there are new technologies, new drugs, new medications coming into the market that are essentially changing the way that people practice, we would probably also consider revising prior to the 5-year mark. I think 5 years is a good compromise, but of course, if you have capacity to update it sooner, that would be great. Everyone is very excited about the concept of living guidelines. I don't know if you've heard about it. It's been out there for quite some time. It just means that you're continuously updating your guideline. Every 2 weeks, every month, you're checking the evidence and you're making changes based on what you find. It's a model that it's possible if you have a very topic-specific focus. So say, for example, that you are part of the Stroke Foundation or Diabetes Foundation, that's your focus, and you potentially could apply that modality. If you have a work plan, if you have to move to other topics as well, I think it's a little trickier. So it just comes down to resources, really. Okay, let's see. Clinicians often rush to conclude. How difficult is it to keep them on track with the ETR framework before even considering the evidence? It is a bit difficult, but I must say that the expert groups that we work with, they are super committed and really trusting in the methodology and the process. So I guess the temptation is to rush. The temptation is to recommend what we think we know. But once going through the process, I think the added value of ETRs and other factors and deliberations becomes very apparent. So it might be sometimes difficult, but I must say that in my experience, the value add of this tool is quite apparent to everybody involved. Who will decide which perspective of the guideline? The guideline team or the guideline panel. So when you set up to do your guideline, based on the scope that you have, based on what you hope to achieve with your guideline, you will be responsible to decide. And the most important thing is to, again, lay it out, make it transparent, write it up in your introduction so that everyone knows when they're reading your document which perspective you're taking. Oops, sorry. Okay. I'm going to take maybe another one. How many people should there be in the panel? Very good question. I'm afraid I have a similar answer to what I gave a few times, I appreciate now. No right or wrong. I suppose you have to keep it manageable. At ACE, we've grown our expert groups compared to a few years ago. I think right now we're looking at about between 15 and 20 people. It comes down to the scope of your guideline. How many specialties do you need to have represented? How many settings do you need to have represented? Do you have capacity to include patients? Do you have capacity to include other people that are not healthcare professionals or patients, maybe policymakers or others? So try and balance representation for what you need in terms of commenting on the scope of the guidelines that you're planning to do, as well as keeping it manageable in terms of numbers that you will have to collect feedback from, that you will have to coordinate, get everyone to come to meetings, etc. So yeah, at ACE we have between 15 and 20 people on our panels. Mindful of time, so we will move on with the second session, but again, if I haven't responded to some of your questions, please come and find me. I'd be very happy to have a discussion with you. Thank you.
So, as she mentioned, so my name is Johanan. I'm a guideline developer at ACE, and I'll be bringing us through the second half of the session. So Valentina has covered the what and why of ETRs, and now we'll look a bit more at the how. So how do you populate or fill up an ETR framework, and then how do you use that to make a recommendation? So the first step is to determine the guideline perspective, and I think there were some questions on this as well. If you recall, the guideline perspective is very important because it determines the type of questions you ask. So as Valentina mentioned, using the example of psychotherapy, the questions that you ask when you consider psychotherapy in an individual patient point of view, are they receptive? Are they able to engage in therapy? Is a little bit different when you adopt a population perspective, where you would ask those questions, but ask other questions like what's the system capacity in terms of manpower? Are people trained to provide this service, etc. So that's the very first step when you want to start filling up an ETR, is actually to start with the perspective. So ACE adopts a population perspective, and we will cover this segment using this perspective as well. So then the second step is to select the framework that you will use. And as we saw in session 1, there are many different frameworks out there. GRADE is the gold standard for guideline development, and that is what ACE's ETR is based on. So under this ETR, there are 5 domains. So the balance of benefits and harms, certainty of evidence, values and preferences, resources and feasibility, and finally acceptability and other considerations. So we will go through these each in turn, and for each domain we will cover the questions that should be addressed by the panel and where to look for the answers. So if you know these 2 factors, that will help you populate your own ETR for your guidelines. And to make this run through a bit more concrete, we'll use an example from our chronic coronary syndrome or CCS guideline to kind of illustrate what we mean by each domain. So the question we're looking at for this guideline was, should clopidogrel be used first line for patients with PCS instead of aspirin? So essentially we're comparing two medications, that's the question, and we want to form a recommendation of which one should be used first line. So we'll start with balance of benefits and harms. So you would look at what are the health benefits and risks associated with each intervention. So in this case, the two medications, clopidogrel and aspirin, and what is their magnitude. And where you would look for the answers is mostly in clinical evidence studies. So in this case, meta-analysis of randomized controlled trials. Meta-analysis are preferred over the primary studies because they provide a more accurate estimate of the clinical effect because they pool all relevant RCT data together. So that's why we favor meta-analysis. Sometimes you might be interested in long-term adverse effects of medications, and these are sometimes not studied in RCTs, which the follow-up time tends to be a bit shorter. So you may need to look for meta-analysis of observational studies as well. And if these are not available, then you would have to go down to look at the primary studies. So in our case, there was randomized control trial or RCT data to suggest that there's an increased clinical benefit with clopidogrel compared to aspirin. For example, 45% reduction in stroke risk. And the safety profile of the medications were quite similar. So just based on this, you might think that clopidogrel has the advantage. But we're about to see why it's important to go through all 5 ETR domains before you make a decision. Okay, so next is certainty of the evidence. And the questions to ask here are pretty standard. So there are 5 standardized questions that should be asked for randomized controlled trial findings. And the answers to this can be found in various places listed on the right. In systematic reviews. In the interest of time, I won't go through the charts within the systematic reviews and how to read and extract the information, but what I'll do is I'll outline what each of the questions mean. So the risk of bias refers to the quality of the individual studies. So for example, in RCTs, was blinding done adequately? Is loss to follow-up an issue, etc.? Inconsistency refers to whether the RCTs reported similar or dissimilar results. Indirectness of the evidence, number 3, refers to whether the studies match your research question. So for example, if you are interested in the effect of a medication in elderly patients over, let's say, over 70 years old, you then have to check if that randomized controlled trial you're looking at whether that age group was actually represented. So if it's not, then that would kind of be more indirect evidence. Number 4 is the imprecision of estimates. So this is the confidence we have in the estimate. So for example, we're talking about aspirin and clopidogrel, so 45% risk reduction for stroke. But this estimate usually comes with a 95% confidence interval, which tells you how certain you can be about the estimate. And lastly, publication bias, which is to try and assess whether RCTs that reported negative or null findings had been excluded from the systematic review. So in our case, the finding that clopidogrel had greater clinical benefit than aspirin, upon further examination, we realized that the quality of the evidence was actually low for that due to the risk of bias in the RCTs. Both medications had proven efficacy compared to placebo, so they're both effective, but notably the evidence base was smaller for clopidogrel compared to aspirin. So aspirin had 12 studies and clopidogrel only 4. So now we begin to see that your conclusion about these two medications would be quite different if you had just stopped on the previous slide of the benefits and harms. And I think in the word cloud just now, a lot of the focus is on the efficacy and the safety, which is good, but this helps to illustrate that the certainty of evidence is very important as well, because when you put them together, actually the evidence base is stronger for aspirin. But nonetheless, we're not going to make a decision just yet, so we still have to go to the next domain, which is the values and preferences. So this captures how patients value outcomes, and knowing this helps the guideline panel decide which outcomes they would give more weight to. So, for example, patients may value risk reduction in stroke a lot more than mild side effects, temporary side effects of medication. So when the panel is reviewing the evidence, they would give more weight to the outcome of risk reduction compared to any mild side effects. Of course, it is a bit different if the side effects are severe. So questions to ask would be which outcomes matter the most to patients, and also if there's any variability or uncertainty in discerning the valuation of outcomes. And you would look for the answers in a very different place. So you'd have to move away from RCTs and look instead at qualitative studies. Once again, systematic reviews are preferred because they pool the relevant studies together. So systematic reviews of qualitative studies, it could be studies where they do focus group discussions with patients or in-depth interviews, as well as studies that report health state utility values. If you're looking at primary studies, then locally conducted ones would be preferred so that you have more assurance that the findings accurately represent the patients in Singapore. If there are no published studies, you could engage with local patient groups, and if all of these are not available, you could look at international guidelines on the same topic, because some of them actually conduct their own patient focus group discussions and report the findings. So an example would be the US Department of Veteran Affairs, Department of Defense, or VA/DoD guidelines. They actually do their own patient focus group discussions and report the findings. But of course, you would have to then triangulate their findings with your own clinical experience or engagement with patients. If even that is not available, then you would have to maybe go a step further and get the information indirectly from perhaps clinicians in your expert panel to get a sensing of which outcomes patients value the most. So in our example with CCS, stroke and myocardial infarction were valued similarly. So there were no major concerns with this domain, or nothing to distinguish between the two medications just based on values and preferences. Okay, the next one is resources and feasibility. So under this domain, basically you're trying to discern how practical it would be to implement your recommendation. So you look at resources, so not just cost, but manpower as well. And whether it's feasible to implement, is the infrastructure already set up to integrate the recommendation in practice? Is it cost effective? And so once again, you kind of have to move away from RCT data and look at other sources of information. So you might have to look at your institution costing data, you might have to talk to administrators, clinicians, etc. For cost effectiveness, you can look at published economic evaluations. Because these studies are based on models that are very contextualized to settings, local studies would be preferred. So in our case, we actually realized that there were some practical considerations with using clopidogrel. So patients might need to switch to aspirin before elective procedures, and if there's aspirin intolerance or allergy, then it's a bit more complex. So there were some considerations with using clopidogrel. And the last domain is acceptability and other considerations. So under this domain, you would be asking, is the intervention acceptable to the stakeholders? So stakeholders are not just patients, it would be clinicians as well, and perhaps even caregivers, depending on the condition that you're interested in. And then we also want to ask, number two, is whether patients have a preference between treatment options and the degree of variability in their preferences. So similar to values and preferences, you would have to look at qualitative data or engage with patient groups. For our example, there were no significant concerns to to distinguish between the two medications that we were looking at. So this is the 5 domains in the ETR. And so by going through each of the 5 domains and systematically answering the questions on the left side, it helps you to pull all the available and relevant evidence together. So that's an important step, but now comes the tricky part. So having gone through all 5 domains, the panel will need to combine them or pull them all together and weigh them to determine 2 key ingredients of a recommendation. So one is the direction. So are you going to recommend for or against clopidogrel in this case? And the strength. So to what extent are you going to recommend or not recommend the intervention? So there are 2 strengths of recommendations. So strong recommendations are usually made when we are confident, so that's why it's moderate certainty evidence, that the benefits clearly outweigh the risk. For conditional recommendations, it's usually made when the judgment is not so clear. So perhaps the magnitude of the benefits and magnitude of the harms are actually very close. Or the evidence is of very low certainty or low certainty, or perhaps there's a lot of variation or uncertainty with acceptability, values and preferences, or there are significant feasibility or practical concerns with the recommended intervention or medication. So this is just a rule of thumb, and there are exceptions, which we'll cover an example of an exception in a moment. But basically, this slide helps guideline developers have a rough idea of when to make a strong and when to make a conditional recommendation. So it's very helpful for developing guidelines, but not only that, it's important to know what the implications of different recommendation strengths are for clinical practice on the ground. So because there are 2 strengths of recommendation and 2 directions, in general there are 4 kinds of recommendations that a guideline can make. So you could make a strong recommendation for something, conditional recommendation for something, conditional recommendation against, or a strong recommendation against. So what does this mean for the readers of the guideline, healthcare professionals who are reading it and applying it for their practice? So for the strong recommendations, it's a bit more straightforward. So basically, it means that most patients should or should not receive the intervention, depending on whether you're recommending for or against. For conditional recommendations, what it means is that the decision on applying the recommendation may depend a bit more heavily on patient-specific considerations. For example, maybe the balance of benefits and harms are very close, or there's a lot of uncertainty about whether the intervention is acceptable to patients. So then you might need additional time to make a deliberation with the patient. And so in the literature, conditional recommendations are sometimes called weak recommendations. We prefer to use the term conditional because weak implies that they are less valuable or useful than strong recommendations, and that is actually not the case. So conditional recommendations are valuable as well. So they still take a position on supporting or not supporting the intervention. What they do is that they flag the recommendation as one that would require a bit more deliberation and tailoring based on the patient-specific considerations. Now, just to be clear, strong recommendations also have to be individualized to the patient as well. But this aspect is just more magnified for conditional recommendations. On clopidogrel and aspirin. So what did we decide? So putting all 5 domains together, so we see that while clopidogrel had some evidence suggesting it was superior to aspirin, the certainty of evidence was low, which means we cannot be confident in the findings. We can't be confident in the findings on the far left. There were no major issues with values and preferences or acceptability, but there were some concerns or considerations with using clopidogrel. And so the expert group for this guideline, pulling all this together, decided on a strong recommendation for aspirin and a conditional recommendation for clopidogrel as an alternative. And so the key takeaway here is that the reported balance of benefits and harms from the RCTs were considered alongside the certainty of evidence, which allowed the group to realize that actually the evidence base is stronger and more established for aspirin, which led to the strong recommendation for using it first line. Okay, so if you recall, we mentioned that while this diagram is a rule of thumb to decide between strong and weak recommendations, there are exceptions. So you can make a strong recommendation even with low certainty of evidence if there is appropriate justification. And we're going to look at an example from another one of our guidelines, which was on generalized anxiety disorder. So the patient group we're looking at for this question were patients with severe GAD or generalized anxiety disorder. And the question was, should we prescribe a combination of psychological treatment and medication? So there was some evidence of benefits, but the certainty of evidence was very low. And there were no other concerns with the domains. I think there was a question on illustrating the population perspective, so I'll just point out for resources and feasibility, we considered things like what is the current capacity for psychological treatment as well. So that's something under a population perspective you would consider, because you need to know that the system has the infrastructure to support the recommendation. Okay, so nonetheless, overall, because of the very low certainty of evidence, if you follow the rule of thumb on the previous slide, the most you can go is having a conditional recommendation. However, the expert group also considered the risk if combination treatment is not offered to patients with severe GAD, and they knew that clinically the intensity of treatment should match the severity of the condition. And lastly, they had clinical experience of using this treatment approach. So therefore, they decided to still make a strong recommendation for combining psychological treatment and medication as first line for patients with severe GAD. And the takeaway is that the very low certainty of evidence was there, and I think someone asked about the weightage, but it was also held against the clinical need of patients with severe GAD and the expert group's clinical experience. So this led to a strong recommendation. So it shows that exceptions can be made with appropriate justification. It is, however, important, as Valentina mentioned, to be transparent. So in our guideline, we included a little box to say that the recommendation strength was based mostly on expert consensus. Okay, so what we've covered so far is how to fill up an ETR from scratch and then use that to develop a recommendation from scratch. But what if you are not developing a guideline from scratch? What if you are adapting from another guideline? So evidence to recommendation frameworks are still very important in guideline adaptation methods. In fact, if you want to adapt from another guideline, you need a guideline with a well-developed ETR framework. So what I mean by well-developed is that they would have listed the domains they considered. So this is a guideline from the States on depression. So they listed the roles as the domains that they considered. They largely should look similar. They mirror the 5 domains that we talked about, and the judgments on each domain. But they go beyond that. So for each judgment, they highlight the supporting evidence that they use to make that judgment. So if you are adapting, if you want to adapt from a guideline, you would need to identify one that is as thorough as this. Because once you have this, what you then do is that you use their judgments as a starting point, and then you update them based on the local context. So for example, here under resources, they say moderate cost of therapy, but the cost in the States and the cost in Singapore could be quite different. So you have to update their ETR framework based on the local data, or you could update it with new findings that this guideline had not considered. So for example, perhaps after this guideline was published, there was a new landmark trial that changes some of the balance of benefits and harms that this guideline couldn't take into account. So then you would update their ETR framework with the studies that you have found. So in this way, you use their ETR framework as the base, and then you build on it to develop your own. So that's the ideal case, but what often happens is that it's difficult to find guidelines with such a well-developed ETR framework. So then the question is, what do you do? Is that you then have to kind of go back to developing one from scratch, as we discussed. But of course, you can use the evidence and the discussion points that that guideline had published to inform your decision. Okay, so I'll just wrap up by summarizing what we've learned. So we've gone through the key domains in an ETR. So there are 5 of them, and essentially these are the key considerations that a guideline panel should take into account when making a recommendation. And as we've gone through the domains, we've seen how making a recommendation means going beyond RCTs. So you need to look at qualitative data, you need to look at costing data, acceptability, etc., so that you can make a well-rounded decision. And based on the balance of all ETR domains, you can decide on the 2 key ingredients of a recommendation. Anybody want to guess the D if you remember? Direction, yeah, thank you. And strength, thank you. Okay, yeah, direction and strength, very important to remember. The 2 key ingredients of recommendations. And then the last important takeaway is that even if you are using a guideline adaptation method, you still need to use an ETR. So it's not, it can't be replaced. It's an essential part of guideline development. So you need to use an ETR and you need to identify a guideline to adapt from that has a well-defined ETR for you. Okay, here are a list of key references for further details. And yeah, that's the end. So we've looked at the how, but really the best way to learn is by doing. So after the break, you'll have a chance to fill in your own ETR and make your own recommendation from our hands-on exercise. But we have a bit of time for the break, so maybe I will see if there are any questions.
Thanks, Johanna. We have some questions on the Slido, so we'll start from there, but at any point, just raise your hand or send us more. Good news, they're keeping tea and coffee until 11, so we know that we all need to go and get a cup, but we'll try and get to a few questions first. Great, so we have a question asking, some organizations draw a difference between guidance, more rapidly updated, and guidelines. For example, the IDSA, which is the one of the infectious disease bodies. Can you share your thoughts on this? Guidelines, guidance, care pathways, care protocols. Sometimes these are all used a little bit interchangeably. We ourselves were called guidance until not long ago, and the decision for us was so that we could reflect the user-friendly look of our products. You know, they're not your typical CPG, 100 pages, they're very short, 10 pages, so that's why we called ourselves guidance. But we decided to update our name to guidelines because we are using guideline methods. We are applying that trustworthiness definition that we saw from the WHO. My view is that if you are developing a guideline proper, based on the methodology and that definition, it is very helpful to call it guideline. If you decide to call yourself guidance, that's totally fine. Perhaps it's helpful just to clarify what you mean with that terminology, if there's any difference. But really, as long as it's transparent, I believe, at the end of the day, healthcare professionals, other users just want to know, okay, what should I do in this situation, right? Looking at the upvoted, what is your sense of our Singapore guidances or guidelines? Oops, sorry, I lost it. What proportion are correctly using ETRs? We did have a look across, and there are many guidelines developed, for example, by the Academy. Some guidelines are developed by the care institutions. I think in general, ETRs were not something that we came across very commonly. Now, it could be that they're not used during the process. It could be that they're not made publicly available, so we cannot tell. So I think there's definitely an opportunity to maybe improve on that. If you are already developing ETRs, just consider making them public. When you publish your guideline, as we said before, it really helps with the transparency and adoption. How long will you take to complete one guideline using an ETR? Okay. So how long you take to complete the guideline largely depends on how many questions you want to answer. How large is your scope? Internationally, everyone is getting so busy, there's so much evidence, so much new evidence every day, that everyone is moving towards a place where they want to be very targeted in their scope. So many guideline organizations are moving away from your traditional textbook approach, where you go from screening to management, referral, everything under the sun. And they're really trying to identify what's the problem. Is it the problem in diagnosis? So we'll focus our guideline on that. Is it the problem on titrating medication? So we'll make a focus. We know that problems are ubiquitous. There will always be many, many problems, but if you have a chance to get a sense of where the larger gap is, that could be your end goal for the scope. And you could also craft questions, maybe not 50 questions, maybe you can have 20 questions. Of course, if you want to have 50 questions and you have time and capacity, there's nothing wrong with that. It will take longer to do the guideline. Our guidelines usually have about 20 questions, 25 questions, and we take 12 months. But we are a full-time team doing this. We know that clinicians have their clinic work, and then they do this in the evenings or in the weekends, right? So it's not uncommon to take a couple of years, perhaps, to come up with a guideline. This for the guideline. If you're doing an ETR, so a single ETR depends really on your experience, on how much information you've gathered. One ETR could take you between maybe a couple of days to a few more. As you become more experienced, it could take you just a day or half a day, depending on the extent of the question. Maybe we take one more before we break for coffee. Will the hierarchy and imbalance of power affect consensus making in expert panels? Yes. Yes. That's a very, very significant consideration. One of the standards in guideline development really focuses on putting together expert panels that are balanced in their representation, seniority level, settings, and so on. And a key thing that we've learned along the way is it's very good to appoint a chair or a co-chair couple who could really focus on facilitating the discussion, okay? So people who are good at, right, we've been discussing this for 30 minutes, we know there are different views, let's bring it to a close and they can provide that weight. Now, consensus is no longer defined as getting people around a table and seeing if everyone is kind of like nodding or if someone is looking down, like does that mean consensus? So truly you should find a method that allows each and every person in the panel to give you a vote or give you a rating or an input. That is equal. That everything will be considered equally. We will have a couple of minutes later where I can show one of the methodologies that we've adapted from. It sounds complicated, but realistically, it's just a back-end formula that allows you to statistically detect consensus. So you could have very powerful voices in your panel, and then you could have people who are a bit more shy. But everyone gets a chance to express their vote, and statistically we can tell whether you've agreed or not. And then of course there will be deliberations. Having a good chair always helps to kind of get people together and reach a conclusion. All right, We will break for 10 minutes. So if I could get everybody back maybe by 10:15, that would be fantastic because then we go into the exercise part. Thank you so much.
Thank you for coming back on time. So you've heard from Valentina and Johannin, and now it's time to switch gear a little. So the team has planned an activity that we hope is meaningful and a bit exciting. So my name is Winnie, and I will brief you on the hands-on activity. So everyone here has been invited to take up the role of a guideline panel today and develop a recommendation on first-line treatment for adults with type 2 diabetes, newly diagnosed type 2 diabetes, using a population perspective. So the context for this guideline is that the clinical landscape in diabetes has shifted in recent years with new medications emerging, which has led to uncertainty among primary care clinicians who commonly diagnose and start patients in the community on medication. So for many years, drug A has been widely used as first line, but with more studies accumulating on drug B, the time has come for a new guideline. So this is where you come in. So in this activity, you have the chance to assess the ETR individually before coming together as a table to decide on the recommendation strength and direction. Please note that we have modified the exercise such that it can be completed in the time available. So, yeah, parts of it have been provided to you, and it's not possible to run a consensus exercise, unfortunately. So we will just maybe share a little bit about what we do with the ACE expert groups after the exercise. So there are 3 parts to your task. You'll see some worksheets in front of you. So first of all, just check that you have worksheet 1 and 2 for yourself. This is where you will write your answers individually. So worksheet 1 is for you to write your judgments. You should all have a pen. If not, please just ask someone for one. And worksheet number 2 is information for the expert panel. So you should have both of this. In the first 15 minutes, your task is to go through individual judgments and make an overall assessment for each domain. Please don't worry too much if you don't finish in the time available. Please just move on to the next step because you can still think about it in a group discussion. So I hope we have both worksheets. If not, just raise your hand and someone will help you. So as a recap, the 5 domains in the ACE ETR framework and the questions to think about. You will not have to assess certainty today. We have done it for you, so it's provided. The second part is to discuss each domain as a table. So everyone at your table is part of your panel. You should have an A3 piece of paper labeled number 3 with your table number and to basically discuss and agree on each domain's overall assessment. So this may require a bit of sharing of your knowledge and experiences, and we have assigned different disciplines to each table. So hopefully this is fruitful. We will make regular announcements on the time, so you'll be reminded to move on to the next step after 25 minutes. Okay, so that's part 2. So in the final 10 minutes, you have a total of 15 minutes for this exercise. In the last 10 minutes, please integrate all considerations that you have discussed and decide on the recommendation. You have to submit this by Slido, so 1 representative per table. Please later submit by Slido. It's okay if you did not finish discussing all the domains. Maybe you could come to a conclusion based on what you have discussed. That would be great. So at the bottom of the A3 piece of paper that you see, you'll see a space for you to write the direction, the strength, and the population. We've also given you examples of how you could write your recommendation. So yeah, this is a reference for you for the Slido submission. So at the end of the exercise, you should have a total of 15 recommendations. Okay? Alright. So recapping again, this is how you pull together all 5 domains to decide if you recommend drug A, drug B, and to what strength. And for this exercise, you will have Apple staff stationed nearby to answer any questions you have or help you out if you're stuck. So I'm just going to introduce them to you so you know who they are. So starting from tables on my left, so tables 1, 6, and 11, you're paired with Valentina. Yeah. Tables 2 and 7, you can approach me. Tables 3 and 8, Fo. 4 and 9, Yicheng. 5 and 10, Johannin. Yeah. 12 and 13, Carolyn. Okay. And then 14 and 15, Veronica. Okay. Yeah. So if you need help, just raise your hand. So one last thing before we start, I will breeze through the evidence table and the worksheet prompts. Okay, so this is in your worksheet too. As mentioned, drug A is the current first line of choice, and while there are very few head-to-head trials between drug A and B, you have data on how each option compares to usual care. So in the first column, we have outcomes listed, the benefits in green, potential harms in pink. Please take note that some are actually mean differences, so HbA1c is a mean difference. Others are number of events per 1,000 patients, so cardiovascular death, for example. So for most of the outcomes, you're actually looking at a greater reduction as the better option. The ones that in bold are the significant events, so you can also read those footnotes. So next to the numbers, you will actually see the certainty of evidence, which is very low, moderate, high, etc. So how do we read this? These notes might help you with, you have notes on the bottom of the worksheet to help you with that. So the higher the certainty, the more confidence you have that the estimate is close to the true effect. For example, we can really say that drug B results in fewer cardiovascular deaths because the certainty is high. In contrast, if it's very low, you are less confident in the estimate. So in this example, it's very uncertain how drug A affects cardiovascular deaths based on the data available. Okay. So as an individual, and then coming together as a group, I'll just go through the questions to think about very quickly for you to make an overall assessment. So you'll see these options in your worksheet 1. So as an example, after going through the different considerations for balance of benefits and harms, ultimately you want to decide whether drug A is favored, drug B, or are they actually quite similar. So make your own individual judgments and then you can come together in the second part. These are the options for certainty of evidence. So for all other domains, just showing you that the examples have been provided to you as a starting point. So please layer on your professional experience, your knowledge, and yeah, so this example is for values and preferences, which is how patients value outcomes. Have a think about the questions for values and preferences when you get to that domain, and ultimately you can decide whether most patients would value the same outcomes or perhaps quite differently. Resources and feasibility, again, these are examples, so feel free to supplement these. And then have a think about whether it favors drug A, drug B, or it's actually quite similar. Last but not least, this is the information provided for acceptability, so you can think of more examples if you have them. And I come to the end of the prompts. Are there any quick questions before we start? If not, okay, good luck. So please start with what you want to maybe can we have a timer as well? Thank you.
If you haven't done so, you can use the QR code. If you've already submitted, you can go for a quick break. We will have a discussion just before entries, so please make sure to submit. No right or wrong answers. All right. Can we move to the next slide, please? Okay, after this one? Fantastic. Okay, could I get everybody's attention? Great. Thank you so much for going through this exercise. The team is busy collating your entries, and we'll have a quick discussion soon. But whilst we pull together all of your submissions, let me spend 1 or 2 minutes to talk about what happens in real life, so to speak, after you populate an ETR. Well, one of the key standards is to make sure that you have a consensus method as part of your panel. This infographic that you see on the slide is pertaining the G4G or Guidelines for Guidelines document that we published in May. Feel free to go on our website and find out more about it, but if you look at the point number 7, it says use a consensus methodology. Now, what is consensus? I think that's the tricky part. Again, a lot happens during planning for the guidelines. So when you come together and you decide on the methodology, you decide on the perspective, you decide on the ETR that you want to choose, you should also set up the type of consensus method that you're going to apply. There will always be different views, there will always be people that have perhaps different perspectives. At the end of the day, how are you going to bring it back together? Are you going to use a majority voting if it comes to that? Are you going to apply 70%, 80%, or maybe you just want 100% agreement, and that's your definition of consensus? So early on, do make sure that you have an understanding of what consensus is going to look like in your guideline. Always better and more useful to apply what we call explicit consensus methods. That means essentially quantifiable. So as we were saying earlier, just looking around the table and seeing if people are nodding or maybe staying silent, that doesn't quite constitute consensus. It's much better, more reliable to have a quantifiable consensus where everyone in the panel has a chance to express a vote or an opinion on whether they agree or disagree. Okay? Next slide, please. Oh, I'm sorry, I have the clicker. Okay. This is the method that we use at ACE. It's just one of the available consensus methodologies out there, but we thought maybe it would be interesting to share what we do. It's called Brand New CLA. It's a fairly the manual is quite old, it's like back in the 70s or 80s from the US. And it's essentially a way to gather consensus among a large group of experts. The good thing about this method is that it's made of 2 rounds of rating from individual members of the panel. So typically what happens is that individually people will rate, agree, disagree, or any other definition on the recommendations that are being proposed. There is a back-end simple formula that allows you to statistically detect whether there is consensus or not among the group. There is then a discussion, especially on those recommendations that have not received or achieved consensus, and a second round of rating after the discussion. Usually what happens is that the consensus converges after the second rating, and that's because the discussion gives an opportunity to bring up more nuances, more considerations, and also to tweak the recommendations as the discussion happens. There's no limit to the rounds of voting that you can do. We, from our experience, generally speaking, 2 rounds are sufficient, but if necessary, you could go to 3 rounds. We don't have a lot of time today to go into the details of this, nor is the scope of this workshop, but it's important that you clarify when you reach consensus. It's important that you clarify to your members what kind of definition or what kind of information should they look at when providing their agreement or disagreement. So in our case, we ask our experts to provide their votes on each recommendation, considering the very same factors that we have set out at the start in the ETR. That allows us to have consistency among our decision making, and also to make sure that we've captured all views on these very important factors that are underpinned by the grade framework. Before we go into the closing remarks, I think we have some time to see what you have submitted to us in terms of recommendations. So I believe maybe we're gonna put up a slide with 15 recommendations, or maybe more, by the various tables. There's 3 slides, because these are lengthy recommendations. Okay. Winnie, I invite you up here. We're gonna have a bit of discussion. And we're going to invite you to share your main considerations. We don't have time, unfortunately, to get everybody to share because we're already at 11:35. But maybe a few can tell us a bit more about how you've reached your conclusions. There are some tables that decided to make strong recommendations, but specifying the particular population that it applies to. I think perhaps we could start from table 3, if they would like to share their considerations on how they've decided to make a distinction between groups and strong recommendations. Again, there's no right or wrong. We also have no answer for this clinical question, so we're very interested to hear what your perspectives were. Please.
Take it off a recommendation suddenly, so it's a strong recommendation to continue. But the population would be those without risk factors. And those who are very well aware that they did want to have a UTI, because the genetic side effects are significant. So we felt the drug B's strength evidence was good because it's a new drug, so there's lots of evidence. Drug A has less evidence because it's too old. Nobody's going to do any studies on that. So you naturally have a risk, you naturally have a lack of very strong, grade 1 kind of evidence for drug A because it's too old. But the strong evidence is because of its length of use, which is in the population. So drug B is strong for patients with risk factors, and also for those who understand the risk. So patient counseling, those who understand the risk of UTI. So in part of the recommendation, we say you need to counsel the patients with high increased risk, which is what I think they're doing now in the specific drug you're alluding to on the ground, because the patients do come to me and they say they've been aware of it when they get UTI.
Thank you very much. Thank you. Can I ask you, was there, because of course you shared, there's a lot to digest and take into account when it comes to the evidence, the benefits, the harms. Did table 3 have any concerns when it comes to resources or even acceptability by patients? And it sounds like maybe not so much because you ended up with strong recommendations. Or perhaps you did have, but you didn't think that it should apply to the strength of recommendation in this instance.
If you're referring to resources as in cost?
It could be, it's part of resources, yeah?
Yeah, so we kind of went through very superficially the idea that drug A is cheap, it's been around forever, so it's essentially status quo.
Yep.
Drug B is the perennial argument that you introduce something new and expensive to avoid the cost of complications later on.
Yeah.
But then I threw in a consideration that if you didn't die of cardiovascular risk because you took drug B, you die of cancer, which is additional cost anyway, and nobody can cost that. So we kind of left it there.
Understand. Thank you, but I think I agree with the point just made that sometimes we have medications that we're looking at, and they both have subsidy. Of course, we're looking at maybe specifically for public setting, but they're both cost effective in terms of their subsidy decision. Yet one is status quo and one is a change. So considering the feasibility of changing the current practice comes under those considerations for resources. Perhaps there's more training required. Clinicians may not be so well versed with the newer drug, and that adds to the considerations and eventually strength. Okay. Next. Can we take a look at table 8 or table 5 in the slides? Maybe the next slide will be there. Yes. So table 5, for example, interestingly, so there is a strong recommendation for drug B and a conditional recommendation for drug A. Anyone from table 5 who wants to tell us a little bit more about your judgments? Yeah. Thank you.
Hi. Essentially, I think to start off, when our group went through the 5 domains of consideration, actually we ended up with 2 that favors A and 2 that favors B, and for the patient, one that we think that there will be some variability in terms of patient preference. So I think looking at how we actually came up with the first statement on drug B was that because for drug B, the magnitude of benefits as well as the certainty of evidence was strong, and hence we were able to recommend it a bit stronger, and that for drug B specifically, we specified the population that it has to be newly diagnosed and type 2 diabetes, as well as those that have more than 3 cardiovascular risk factors, given that for B, the additional benefits in addition to A1C reduction was that it can also reduce the risk of cardiovascular death, non-fatal heart attack, as well as kidney disease progression. So I think based on the certainty of evidence, we were able to recommend it confidently. For drug A, I think the considerations were quite similar to what the gentleman there mentioned, because we think that drug A, as mentioned, it was actually around in the market for a long time, and hence that's why the certainty of evidence is very low. But I think for most clinicians, they do have lots of experience in using drug A, and that so far there is lesser concerns about side effects as well as cost, and there are patients who would prefer that over having more benefits, because after all, it's not that drug A doesn't work to lower A1C and all, it's just that the evidence is a bit lower. And I think we do think that there are patients who also value reduction in body weight. So I think since both drugs actually do benefit that, then if let's say they do not have any CV risk factors, we do think that it's still a good drug that can be used to well control the diabetes well. So the conditional was really more on the certainty of evidence. Yeah.
Thank you. Thanks so much for sharing. Could I get this slide to show another table? Maybe we go to table 8. Yes, where conditional for drug A with a specification on the subgroup, and strong for drug B, again with some qualifiers on the patient subgroups. Maybe table 8, yeah. Would you like to share a bit about your considerations and judgments?
So for table 8, I think we first rationalized that whatever recommendation we would make would be separately for each of the drugs.
Okay.
Because we have studies that compare either drug to usual care but not to each other, so it would be very difficult to draw inferences about comparative efficacy of these 2 drugs. We have drug A, which is has been around for a while, but the level of evidence from important endpoints was lacking. However, there's also lack of significant side effects, although again, the effect estimates may be imprecise. For drug B, one of the key considerations was that there was high level, high quality, precise effect estimates for important cardiovascular chronic kidney disease endpoints in addition to weight change as well as HbA1c. However, a significant concern was a very high absolute risk of GU infections. So actually there was quite heterogeneous opinions in our table. To a certain extent, we quantified with how many were voting for or against, and we settled on criteria for the majority would factor into this recommendation, and so that's what led to these recommendations.
Thank you so much for sharing. And yeah, I've noticed that some tables did start to apply voting methodologies as they were going through the domain, so that just organically happens with consensus reaching. They're telling me to go to table 12. We conditionally favor drug A to be prescribed as initial first-line treatment for adults with newly diagnosed type 2DM. Table 12. And there's another, another that maybe is not captured in the slide. For patients with more than 3 CVD risk factors, can consider the use of drug B as initial first-line treatment for adults with newly diagnosed type 2DM. So two conditional recommendations. Can we hear a bit more about your discussions?
So I think the initial points about favoring drug A was made in the context of trying to make a decision between drug A and drug B. I think having listened to the discussion, that perhaps it would be more reasonable to compare it against usual care instead of against each other.
Right.
But that's sort of what largely informed the conditional nature of the recommendation, along with as well some of the other points about the evidence being a little bit weaker for drug A, even though we understand that it has long-term usage. A lot of the drug A itself was favored for the table largely because of its historical use as well as some of the other cost considerations. Another point of note was that while we did see that drug B did have significant effects for like statistical effects on the CVD factors, we weren't sure that the effect size was sufficiently large enough to translate that into clinical significance as well, because it's like 6 or 5 out of 1,000 people.
Yep.
Yeah. And none of us were clinicians, so we're not sure whether 6 out of 1,000 is a lot, but it didn't sound a lot. But then, and also because the initial evidence table itself looks at patients with cardiovascular risk factors as compared to the overall recommendation, which was against just anyone that had been newly diagnosed with T2DM. Yeah. So that's what informed that first recommendation. The second recommendation is just as a nod to the fact that because it does have some of these effects, it may be more relevant to individuals who do have these risk factors that they want to consider that that's actually this better drug that has shown some effects on these sort of pertinent factors. Yeah.
Thank you. Yeah, and a very, very important point brought up just now that for the purpose of this exercise, the information that was provided largely focused on statistical significance, so whether you can detect that, and it was marked on the sheets. But when we judge benefit-harm ratio, a big component would be, even if we see a statistical significance, is there actually a clinical significance? So is the effect estimate big enough, so to speak, that would make a clinical difference to patients? And how do we determine that threshold or that number? We can look into the evidence. There is a body of evidence published on clinical significance for particular scales or particular symptoms or other factors. If we don't find that literature, we can always gather the knowledge of the panel. So from clinical experience, if we're using a certain scale or HbA1c, change in percentage, how much does it need to change to make an actual difference for the patient and the patient outcomes? So that will need to be taken into account besides the statistical significance itself. Awesome. I think maybe I'll just open to the floor and see if anyone else would like to share other judgments or considerations or factors that their table went through. If not, was there any particular domain that was quite challenging compared to the others? Or they were all equally difficult, or maybe a couple of them were a bit more tricky? Yes, they were. Thank you.
So apart from the cost, which is more like the direct way of comparing, so the more tricky part was like how many cardiovascular events would drug A lead to, and what sort of hospitalization costs in the long run. So that's sort of hard to estimate from the data now. So how do you take that into account?
Again, comes down to, like you already mentioned, do we have any data, any evidence to show for that? And even if we do, perhaps we might not have evidence. Do we have institutional data that can help us, give us a sense? With data sets, we always have to be mindful, the correlation that we see, for example, between drug A and hospitalizations. Is it truly causality, or it just happens to be a correlation? If you don't have that information, that becomes part of the panel's judgment whether not having that information actually is a challenge, is a barrier to make a strong recommendation. But the long-term view, the long-term resource outcomes is certainly something that, if you're taking a population perspective in your guideline, should be considered. And perhaps the panel will make a judgment that, hey, we don't have that information, we cannot make a call, therefore it's unlikely that we will be able to go ahead with a strong recommendation. That's one way of going about it. Maybe you want to add something?
Thanks for the question. So I think we tried to keep it as we could have given you numbers, but I think it would have maybe required a bit more time. But I think for that particular drug, because it had been already listed on the subsidy drug list, so there is some sort of cost effectiveness that has been done. So perhaps some of the costing data could be in there, and you may need someone with modeling expertise perhaps to put together all these different numbers and see how that translates to outcomes, and is it enough? Because like you said, if your population has a higher risk of cardiovascular outcomes, potentially you can save more, right?
Yes, table 13.
I'm just wondering, what is considered usual care in this case? Because since drug A is almost like usual care, it's been there for a long time. And so I'm just wondering what was the comparison? And also, when we consider evidence and go through the literature, must it always be compared to control versus drug B versus drug A?
If you have information drug A versus drug B, that's great. That would be even better. In this case, we didn't have, so we gave you the information that we have for drug A versus usual care and drug B versus usual care. In this case, usual care was defined as lifestyle intervention, diet, and older medications used for diabetes. And we made an assumption that the usual care was comparable between studies for drug A and drug B. Because sometimes usual care is described differently. So some studies will tell you, oh, usual care, but that's, maybe they're doing, lifestyle intervention. Other studies, the way that they define usual care may be lifestyle intervention plus some other things. So in this case, for the purpose of the exercise, we made an assumption that they were comparable in the way that they were defined. But of course, if you have head-to-head trials, meaning drug A versus drug B, that would be even more informative. And perhaps some tables would have landed on one recommendation if they had head-to-head trials for the two drugs.
Let me just add to what Becky said. Some of the tables that I was circling around had this discussion about the evidence, whether they would have, wanted something more than RCTs because this was a meta-analysis. And so this is all a very valid part of being an expert panel, which we're not reenacting, but definitely, as an expert panel, you would critique the evidence that's provided to you, and you would definitely have a longer summary of what's the population, how comparable is it to your patients in Singapore. And yeah, so I think we made it comparable for this exercise, but it's a very valid point. You would critique all of that in a real expert panel.
Okay, questions? Yes, table 6, is it?
Yes, table 6.
Hello.
Okay. Could I just find out in terms of the amount of effort that's required to an expert panel? So when you talk about meta-analysis or published data, do you just look at the published meta-analysis, or would the panel experts need to do their own meta-analysis of all the different meta-analysis and systematic reviews that's present in the papers in the literature? And also, would you actually do a network meta-analysis to compare indirect and direct evidence? So how much effort needs to be, put in? Thank you.
As much effort as you can have time for. No, okay. If there are meta-analyses already published, always good to start there. And that's what we do at ACE. We take an adaptation methodology where, to begin with, we look at other guidelines, not even meta-analysis, we look at other guidelines and we see what kind of recommendations they came up with and why. So we go and check their ETR and we see whether we can take that into account and adapt. That saves you time, because sometimes it means you only have to adapt one of the few domains. You don't have to do everything from scratch. Now, meta-analysis is very good. You could just look at those if you have meta-analysis that answer your question, right? A tip or piece of advice would be take into account how recent they are. You might not need to do it from scratch, but you might need to update them. So if the meta-analysis took into account studies until 2020, 2021, and we know that there are newer studies that have come out since then, you may be able to update that existing meta-analysis with the newer trials as well. Network meta-analysis, wonderful method. I think if, again, capacity allows, it would be always a good thing to do if you need that head-to-head comparison. There are great papers on interpreting the certainty of evidence when we're looking at network meta-analysis. This has been quite contentious for some time, and generally speaking, panels were not very comfortable in making recommendations based on network meta-analysis because you're using indirect evidence. But GRADE has come up with a framework or a bunch of rules to judge the certainty of those data as well. Yes, table 8.
My question relates to how we involve patients' view in this process. Other than relying on literature scoping for qualitative studies or quantitative studies, is there a well-established method for how you select members of public or from the patient population, how you conduct these discussions, their presence, any frameworks or tools that we can use?
Thank you. Thanks for this question, which is, I think, important to all of us. You're absolutely right that looking at qualitative evidence as part of the CTR deliberation process is good, but maybe not enough. Generally speaking, if you could appoint 2 patients minimally to your panel, they could be patients, they could be carers, they could be people with lived experiences, which is a bit broader than patient only, that would be fantastic. Now, the problem with appointing patients to guideline panels is that you need to make sure that the literacy of these patients is sufficient so that they can meaningfully take part in conversations. If you look at standards in guideline development, everyone will tell you you need to have patients on your panel. That's considered, the standard. But oftentimes it may end up being a tick box exercise, oh yeah, we do have patients. Then these patients are not prepared to contribute at the same level as doctors and other clinicians to the discussion. So for us, for example, we would love to get there, but we need to invest some time and processes to build up that literacy and build up that safety net to make sure that they are supported in contributing. In terms of recruiting, there are probably a few ways to go about it. You could ask your panel members who are doctors and clinicians if they have certain patients who would be suitable to take part. Or you could go via patient group representatives in the hospitals, in the institutions. At the end of the day, if you're appointing them to your panel, you need to take into account that they will have equal vote as clinicians, which is great, but it also means that you need to equip them with the right information to do so, right? Another way is to not appoint them directly to the panel, but to conduct interviews or surveys, collect that information firsthand from these methodologies, and then bring that information to the panel who's deliberating. It's a slightly more indirect way of doing it, but probably still better than not at all. So we're piloting this with one of our topics at the moment. It doesn't replace the evidence, but it's an adjunctive piece of information from local patients that we have. Yes, so maybe we, yes. Phyllis? Oh yeah, she's here. Maybe we can go to the closing remarks, and if there are more questions, you please do come and find us after the workshop. We'd be very happy to discuss further. Thank you so much, though, for your contributions to the exercise and just now. Thank you.
So, as we come to the close of today's workshop on the ETR, first and foremost, I just wanted to say a very big thank you to Valentina and the team from EPPO who had helped as facilitators, logistics, admin, support. Please, can you join me to give them a very round. And of course, second, thank you to all of you as participants today for very lively team discussions. Certainly in my table, it was great to see how passionate you were about the need for such frameworks as the ETR, for good evidence and data, for transparency, which is a big word, as well as the need for patient voice. So, today's session marks not just the end of a workshop, but the start of a stronger ecosystem for evidence-based medicine. So I'm very delighted to officially announce the launch of the ACE repository for clinical guidelines. This is the central platform that I mentioned earlier that will house, curate, and share locally relevant, high-quality guidelines that meet our G4G standards. I encourage each one of you as early adopters to consider signing up if you are considering developing a guideline at the start of it, or even if you are interested in getting involved with our work here in ACE, to give your insights in our FGDs, or to participate as part of the expert group. So if you do want to have your guideline featured on our ARCG, here are some of the benefits for inclusion. Whilst we will not endorse the guideline in its totality, we will validate the methodology based on your application and based on to what extent you're able to meet the G4G requirements. With that, you can increase your reach because it will be in our repository. We will help you with the dissemination as well, and so you can widen your reach. So here is the QR code, and to sign up if you're interested in any way to collaborate with us. So as we wrap up, I just thought I could leave you with the 3 key takeaways for today. So first of all, of course, use an ETR to develop your recommendations in a structured way. And do go beyond just clinical and efficacy considerations. Consider the certainty of evidence, the values and preferences, resources, and feasibility and acceptability. And last but not least, to determine the direction and the strength of your recommendation. So that concludes our pre-conference workshop. Thank you again for being here, and we'll see you again.